Hello, hello, hello. Good evening, students. Good evening. Am I visible to all? Am I audible to all? Can all of you hear me? Can all of you see me? Yes, I think just maybe from where we are streaming from slightly. Yes, I think we are live now. And thank you very much, all of you, for joining in. We are going to keep it like a quick recall session. It is your day to relax and enjoy. And you can somebody also please comment in the chat box. I don't know, chat box is also working properly. And can I get something in the chat box also? Okay. Yes. So welcome all of you to the to this our NEET PG August 2025 OBGY recall MCQ session. You can get in touch with me on phone and WhatsApp on this number for any further difficulty. This is a recall from all the MCQ that you sent to me. Quickly download the OGGuru app on Android and iOS, and for iOS, do not forget to use the ORG code. And my dear students, thank you very much. I'm so happy that my lectures have really been helpful. Sir, your MCQs, this is just some few of the answers felt so easy. Amazing lectures for the concepts. Sir, I was nervous, but your OBGY get us help very well and could revise quickly. And all of you have been sending so many messages. I have lots of messages yet to be replied, and keep on sending me the questions also. This is all the recalls what we have got, and all those who are now preparing for the November INI CET or even the next year. Many of you have been intern and just given like a trial attempt. Quickly enroll in the master class and you will see the benefit in your improvement, and everything is there. MCQs, discussion test, beautiful handwritten notes are also there. So let us begin. And as I said, today is your day to relax and enjoy. So we are going to keep it like a quick short recall so that all of you. Yes, and can somebody, yes, good evening, Mohammad Mubib, yeah, good evening, yes, okay, so welcome all of you. Chalo, tell me the answer. Very easy MCQ, very easy. I'm sure all of you सबने write किया होगा, सबने तोड़ दिया होगा. Cervical cancer lady, hydronephrosis, hydroureter. What is the answer? So when the cervical cancer, all of you know, when the cervical cancer, and why does this happen? So cervical cancer spreads laterally. Cervical cancer spreads laterally. It engulfs the ureter, giving rise to hydroureter, hydronephrosis, non-functioning kidney. And what is it? Yeah, good evening, Dr. Harish. And what is it? Yes, it is, what was the answer? Yes, 2A, 2B, 3A, 3B options were given, and it is stage 3B, isn't it? I'm sure all of you must have got it correct. Very good, Dr. Harish. And therefore, also remember this, okay, another MCQ also which could be asked next year. So we are there to guide you with all the other upcoming exams also. What is the most common cause of death? If they ask you, most common cause of death in patients of cervical cancer is your uremia. कैसे होगा यूरेमिया? ऐसे होगा यूरेमिया. 3B से होगा यूरेमिया. Yeah, only this question can be asked for shading to yes. Yes, I said thank you, Harish. Love you for that. Okay, yes, thank you very much. As I said, okay, this was the most likely question to be asked, and the prediction was correct. Thank you. Yes, okay. So, commonest cause of death in patients of cervical cancer is uremia, and stage 3B is the answer. I'm sure all of you must have got it absolutely correct. Moving on to the next, loading dose of magnesium sulfate as per the Pritchard regime. Now, please understand this. What also complete total loading dose was asked to you. Okay, and I'm so happy I said this in the reel also, that nowadays doses, this was a virgin MCQ. The dose total was never asked, but yes. So what is the answer? The total loading dose is what? We give 4 gram IV, and totally 10 grams IM are also given. So the total loading dose, absolutely correct, 14 grams. 14 grams is the answer, unless they specifically asked you. So 4 gram is given IV slowly, and then 10 grams, you know, we give IM in each buttock. It is 5 grams plus 5 grams in each buttock. Very good. Yeah, thank you, Gopu. Thank you for joining in also. Good evening. Okay, so this is your 5 grams plus 5 grams, that is your 10 grams IM, and therefore the total loading dose becomes 14 grams. I'm sure all of you must have got this correct. Okay. Is this understood? Anything else? Please tell me if the options were there or something. In this also, I'm sure you told me this option. Okay, so what other options could have been 3A, 3B, 4B, whatever, 4A, 4B. But yes, so wherever we are missing some questions or options, please tell me so that we can also get a complete recall also. Yes. Now this, the students told me that the actual image was given to you. Actual image of an intern or a doctor delivering the delivering this. And what is this? Yes, sir, over here we can see the umbilical cord. Again we had this. Okay, so umbilical cord can be seen. This hand is pushing upwards. So what is this, all of you? This is control cord traction, but the name of the maneuver was asked to you, and this is the Brand Andrews maneuver. Brand Andrews maneuver. Overall, like last year also we had 20 to 22 MCQs in OBGY, and same thing was there also this year also. Till now we got around 20 to 21 to 22 MCQs we are getting it. Yes, modified. Very perfect. Control cord traction or Brand Andrews maneuver. That is the perfect answer. I'm sure many of you must have got this surely correct. Okay, was this the actual image shown, or this was what is the actual picture was shown? Actual image was shown. What was it? Was it, what is this kind of a line diagram was there, or was the actual picture shown? Actual image was shown. That's what the student told me, but that hardly matters, because I'm sure all of you can identify from this. Okay, control cord traction, the name was not there. Okay, superb. So, but control cord traction, but remember this, the name, I have taught you this also, Brand Andrews maneuver. They can modify the question next year and say with another name and answer also. Okay, yes. Now, what is this? Again, I am so happy over here, image based question and an actual real photo. Very good. Okay, thank you. Okay, winging of scapula. Winging of, I told you that it's a virgin MCQ. I had said even 2026 May INICET में आएगा, I jokingly said. Remember, yes or no? Thumbs up if you have seen the masterclass lecture. I said okay, this will come in the INICET. It came in this. And winging of scapula, student told me, was shown also, and winging of scapula was written also. Yes or no? Was it mentioned, winging of scapula? And winging of scapula tells me that it is a winging of scapula tells me that it is a nuchal arm, or basically abducted arm. And you know, yes, in Burns Marshall you hold the baby by leg like this and up, rotate it onto the maternal abdomen, isn't it? Morrissey smelly wheat में malar flexion. With the left hand goes inside the vagina. With the left hand I give malar flexion. Right hand I give shoulder traction. Okay, MSV. Again remember this, in MSV maneuver, in MS you do MS. MS Thokotali, clap, OG in the chat box. MS, do MS. Okay, just by the way, extra information I am giving you. MS do MS matlab, in MS we do malar flexion and shoulder traction, which is of course not over here. And this is the Losset's maneuver. Perfect. Okay, yeah, abducted arm was shown. Okay, superb, excellent. Actually abducted arm was shown to you. Superb, very good. So we all know that this is done for Losset's maneuver. Winging of scapula will be done. It is done for abducted arm, or your abducted arm, or also if it is a nuchal arm. Okay, nuchal arm, virgin MCQ. Great. Super. And reason, we know reason was not the reason, is for the to prevent perineal tear, gentle delivery of the baby's head. Okay, excellent all of you. Now this was again so nice MCQ, and if this was the actual values, you can tell me if the values were changed or something else. So there, FSH high, FSH is very high. LH is also still very high, and our lady is patient is only 35 years old, or I think 36 years old lady was told, whatever it is, less than 40. And AMH 0.1, what does it tell you? Yes sir, AMH 0.1 is very low. I have told you this. Normal, why this? Because normal FSH, I told you normal they are going to give you 5 to 10 ka range mein. So this is indicating, and specifically when it touches 40, and this also, this is your premature ovarian failure, if that was in the option. Okay, if it was in the option, premature ovarian failure or premature menopause, or if this was not in the option, then it also means basically diminished ovarian reserve. Okay, absolutely, the ovarian reserve is gone. How do I know? Because AMH is very low. Okay, AMH 0.1 is very low. So this is, what were the options, anybody? Diminished ovarian reserve. Please feel free to tell me the options, because it's all very good. Swati, premature ovarian failure, superb, excellent. So this is your premature ovarian failure, confirm. I'm sure all of you must have got it correct. Okay, yes, premature ovarian failure, or basically because of low AMH, this one. And why we know master servant relationship, yes or no? Because sir, when the ovaries fail, the master keeps on shouting more loudly कि baba काम करो, काम करो, काम करो, work, 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 yes or no? Like I have told this story also. Okay, when your servant is not working, the master said, yes, thank you, great. Okay, so when the master says that you work more, and therefore master will shout more loudly, FSL is going to be increased. Okay, yes, premature ovarian failure was there. Excellent, that's the answer. Yes, very good. Moving on to the next question, and this is many, yeah, PCOS was also there an option, but you will know why was PCOS not there. The answer, yes, so one option, premature ovarian failure. In PCOS, what will happen? PCOS AMH is going to be very, very high. Very good, thank you. PCOS, good thing to put in the option. PCOS is not the answer. Your premature ovarian failure is the answer, because in PCOS AMH, yes, very good, thank you, correct. AMH is going to be very, very high. High AMH happens in PCOS patients. Excellent. So good MCQ, and very good MCQ. If you see in the match the column kind of a question also, when we have discussed on the in our app and also on the YouTube match the column, we had said that this kind of question would be coming in. Yes, now this was slightly, I think it should not be a problem. Hysterectomy specimen was done, oophorectomy was also done. Hysterectomy, oophorectomy done, and inside the cavity absolutely this growth. Now please understand this, is since obviously understand that otherwise if it is some uterine pathology, if it's some uterus problem, like say example even adenomyosis, only uterus would be removed, isn't it? Only uterus will be removed. Okay, only uterus will be removed, but here something in the cavity. So this is our CA endometrium. Anything clinical history was given? Was it postmenopausal bleeding mentioned tha, ya menorrhagia tha, age of the patient, anything else was given? But clearly some fungating growth. That's what many students have told me, sir, fungating growth within the cavity. Many students told me that yes sir, the image was also not very clear. They should not ask such questions if the image is not clear. But if it's a hysterectomy and oophorectomy specimen, because we know endometrial cancer is, and okay, postmenopausal bleeding, superb, yeah, then it's very much common. Okay, if the patient has presented with postmenopausal bleeding, very good. Postmenopausal bleeding का history दिया है, we know endometrial cancer, because if it's anything else we may not remove the ovary. क्यों निकालेंगे? Because you know endometrial cancer is estrogen dependent. Ovary has to be removed. Ovary has to be removed with this. Okay, so postmenopausal bleeding, hysterectomy, oophorectomy. Yes, please keep on telling me if anything else had some other thing in the option also. Moving on. Yes, again I am so happy all of you. This was the actual case. Students have told me 8 centimeter dilated lady, station -1, cord prolapse. What will you do? Anybody? Was this the question? Yes. So whenever it is a cord prolapse, the main danger is in cord prolapse there is acute severe fetal distress. Acute severe fetal distress. Wait and watch. Postmenopausal bleeding. Wait and watch, you have to go to jail. Yes or no? Wait and watch, you have to go to jail. Again, because of the, we don't do oxytocin augmentation. And what are we supposed to do? We are supposed to fill the bladder. Why retrograde you fill the bladder? So if this is the bladder, retrograde means you fill the bladder with the saline, you fill the bladder so that the bladder will elevate, and this will push the presenting part upwards. So the cord compression, 5 centimeter dilated. Okay, super. Okay, see the cash. Okay, so 5 centimeter dilated instead of 8. Okay, and we will fill the bladder immediately. Very good. This also told you, it's Vago's technique. Okay, retrograde, fill the bladder. Why you fill the bladder? So that it elevates the presenting part up, so it will not compress the cord. Okay, the cord compression, because main distress is because of cord getting compressed. It's very tempting to push to reposite the cord back, but that we should try to avoid. You should fill the cord, fill the bladder that is the Vago's maneuver retrograde, and emergency LSCS. Absolutely, all of you correct, because at 5 centimeter anyway delivery cannot happen. We cannot do oxytocin augmentation. It's going to take time. Primi multi, anything was given in this? Also, you can correct me. Anything more was there? Directly mentioned the cord prolapse. Anything else was mentioned? Was directly cord prolapse only mentioned, or they said some pulsatile mass is felt? What else? ऐसा कुछ दिया था? Okay. Because cord prolapse would lead to acute severe fetal distress, and therefore immediate LSCS or emergency LSCS is the best answer over here. Yes, anything else if you can remember in the question, do let me know. 5 centimeter primi multi, anything was given? No problem. Yes. Okay. So this. Now again this. So happy. Clinical case scenario of shoulder dystocia. How was the case given? That the head has delivered. The head has delivered and shoulder is not. Okay. Very good. Siddharth Sharma, decelerations. Very good. Okay. So that is the fetal distress. Yes. Fetal distress by very good. Decelerations. Okay. Because cord prolapse would lead to severe drop in heart rate, because it's an acute severe fetal distress. Again, if forceps vacuum was there, very good. Cord pulsations felt. Superb. That's what I told you. Okay. Cord pulsations felt. That tells you that it is cord prolapse. Okay. Cord pulsations are felt. Very good. That tells you it is a case of cord prolapse. Superb. Okay. Yes. Moving on. Yes. What was this? Any student told me, sir, head has already delivered. Shoulders are not delivering. So a case of, 5 centimeter, Bhavar Singh. Okay. Shoulder dystocia. And in shoulder dystocia, what you need to keep in mind, never give fundal pressure. Which sign is seen? Anybody? What sign we see in shoulder dystocia? Extra bonus information, turtle sign, extra information. Okay. Also you can, yes, Robbins bhi tha maneuver, Robbins. Okay. Yes. Perfectly correct. So first what you give is, we give a suprapubic pressure. Suprapubic pressure is always to be given first. Okay. Suprapubic pressure is what you give first. Suprapubic pressure you give. Turtles and I mentioned, yes. Rubin also. Okay. So suprapubic pressure is what you give first. Then we go for the Mack-Roberts maneuver. Then yes, if suppose the Rubin's maneuver is mentioned, then Rubin's or the corkscrew maneuver also can be done. What is this Gaskin maneuver? Gaskin means to take it on all four. Take the lady on all fours. It's called all four. Gaskin maneuver, you tell the patient to turn upside ulta and on all fours. So Gaskin and Zavellani, I have told you, it is always the last. Why? What is Zavellani? Because to do a cesarean section, please understand, this is so important. I'm so happy we have discussed this. Let's suppose in shoulder dystocia, basically the shoulder is stuck behind the pubic symphysis. The head comes out and the head hits the recoils against the pubic, against the perineum. Okay. So if the head is out and if all the maneuvers fail, I have to go and do LSCS. But when I do a LSCS, I have to get kachra. Yeah. Okay. Yeah. So basically remember that in LSCS also on the OT table, head only delivers first. Okay. When I do LSCS, it is always head will deliver first. Okay. I've told you this कि आप ऊपर से head को धक्का नहीं मारेंगे. So you will have to reposit the head. Head will deliver first through the LSCS incision. And therefore we will do this last maneuver, which is the Zavellani maneuver, which is to reposit the head back inside the vagina and then do. So jo option mein, in whichever option Zavellani was the last, that will be your answer. Yes. So suprapubic pressure was not there, but then still you remember that Mack-Roberts is done first, then your Gaskins is the Rubin's maneuver or Wood's maneuver, Gaskin, and then Zavellani will always be the last maneuver. Okay. Is this understood to all of you? Now, yes. Now, again, here 2-3 questions were 2 options. There some told me it is a perimenopausal lady, or was it a postmenopausal lady? Perimenopausal lady or postmenopausal lady. And I think heavy menstrual bleeding was also definitely mentioned. Menorrhagia diya tha, ya postmenopausal bleeding was given. What was it? And I'm so happy. And endometrium thickened 12 millimeter was given, endometrial thickness. So what have we told you? Okay, we have to never directly jump for the treatment, anybody with the age of the patient, and we have to always histopathological examination, isn't it? Yes, very good, Swati Panchal. HPE is mandatory, remember this, I have told you this. हिस्टोपैथोलॉजिकल एग्जामिनेशन, एक टुकड़ा लाइनिंग का माइक्रोस्कोप के नीचे आना चाहिए. वाई वी नीड टू डू दिस? टू रूल आउट. वाई एंडोमेट्रियल बायोप्सी? टू रूल आउट. व्हाट आर वी गोइंग टू रूल आउट? एज वाज गिवन 48 और 50. सुपर, हाँ, पेरीमेनोपॉज, चलो ठीक है, 48 to 50 years age. Okay, and I have told you this, you need to rule out endometrial hyperplasia, endometrial cancer first. Okay, because so in fact all the three cancers have come, because you cannot directly jump to and do hysterectomy. Always remember this, very common mistake, people directly say hysterectomy. No, what were the other options? Anyone else? Endometrial biopsy ke alawa what is the other option? Endometrial biopsy is the answer. If here suppose hysteroscopy and biopsy is there, that is the best, huh? Just remember, because you can do a hysteroscopy plus biopsy, that is the best. Okay, hysteroscopy plus biopsy is the best. Hysteroscopy plus biopsy is the best. Just I'm writing, but I think अपने option में खाली endometrial biopsy था. And was other options में what was there in the other options? You can please let me know. What were the other options? Yes. Okay, so just keep this in mind. And endometrial, I think no confusion in this, I'm sure all of you must have got it correct. Okay, yes. Moving on to the next question. Yes, again the repeat, so happy, repeat of this was surprisingly repeat of FMG exams also. Okay, atonic PPH, I think we are in the labor ward. Yes, labor ward scenario. Hysterectomy tha, very good, very good. So directly we don't do hysterectomy. So many times I have told you, hysterectomy tha, we never hysterectomy, we never directly do hysterectomy directly. Why? Because then which operation will you do? You will come to know. So it is very tempting to mark hysterectomy. No, endometrial biopsy is what is to be done first. Remember this, I told you. Yes, very good, super. Okay, and all of you, those who are new, kindly subscribe to the YouTube channel. Also, the new OG membership, OG Circle membership on YouTube has also started. We'll keep adding videos for the members also, and special discount coupon will also be given for the app for the OG Circle YouTube member channels. Okay, now labor ward scenario, medical management for PPH has failed. What is all the medical management? It is all the oxytocin, all the prostaglandins, methyl ergometrin, all that has been given. Very good, Bhavar Singh. What do you do in the labor ward? Balloon tamponade. Balloon tamponade. In India, we can do the condom tamponade, or if you have the facility, even Bakri balloon tamponade. Condom tamponade can be used, or Bakri balloon tamponade can be used. I think in this options, Meta Sigas, we discussed that. Yes, very good. Siddharth Karma, we discussed that. Thank you. Yes, balloon tamponade. I think other options were I think obviously compression sutures was in the option, but obviously before compression sutures and hysterectomy would also be in the option, and ligation of vessels or devascularization of vessels. I think these were the options, would also have been there, but balloon tamponade is the answer and not this directly, because in the labor ward, what next immediate step? So medical management, balloon tamponade, and then you proceed for all this surgical management. Okay, moving on. ये बताने की जरूरत नहीं है. I'm sure you must have jumped up in the chair. Ocipils protective for, all of you know, CEO, colon, endometrium, and ovarian cancer. So colorectal cancer or colon cancer, whatever is there in the answer, we know that. Okay, Ocipils protective for CEO, colon cancer, endometrial cancer, ovarian cancer. Anything else was there? Yeah. Any other Swati, Harish, Bhavar Singh, Gopu, Sidgash? Remember anything in the options? What are other there in the options? Also same one-liner, simple, straightforward one-liner case. Yes. Okay. Okay, this was not there. Okay, yes. Okay. Now Best way, ultrasonography, overlap of radiology MCQ and OBGY MCQ, or as you can say, the combined session MCQ. And this is what integrated diagnosis in the first trimester on ultrasonography. What do we do? Gestational sac is the first to be seen. Biparietal diameter, so we use it later on. Crown rump length, remember I have told you this, the dating scan, this is called as the best way to diagnose the gestational age or to date the pregnancy. Okay, is it clear? Now, dating scan is not when you take your girlfriend on a date and do her sonography. Okay, dating scan is not okay, during we get such answers in Viva. So, dating scan, matlab during dating period, boyfriend will do girlfriend scan, girlfriend will do boyfriend scan. That is not dating scan. Dating scan is to basically date the pregnancy, or that means to date the pregnancy, matlab to determine the gestational age. And dating scan CRL is used. Why? Because CRL is the most accurate. It is the most, the reason for using CRL is it is the most accurate. Perfectly correct. Yes, dating scan joke. Thank you. Yes. Yeah, thank you, Harish. Yes. Okay, super. Okay. Now, again, I think the simplest, let us, very basic anatomy teacher must have taught you. We have taught you probably the simplest MCQ of this year's NEET PG. Umbilical cord contains what? Okay. So, it is containing 2 arteries and 1 vein. And which is that vein? Yes, left is left in the body, because the right vein disappears. All of you know the right vein disappears. How we remember? Left is left. Left is left in the body. Left is left. Okay. Yes, 2 arteries and 1 vein. All of you, I think इसमें mistake मत करना, टेंशन में सब अगर किसी ने by mistake किया है तो, otherwise I'm sure this is a simplest MCQ. Yes. Okay, moving on. Sequence of episiotomy closure, so simple and so obviously if you've gone or even just seen. So what we do anytime gone to labor ward? Nice question. Okay, obviously first we have to, there's a cut in the mucosa. Okay, so first we take the apex and we take a delayed absorbable, or we can use a chromic catgut or Vicryl also. Okay, so first we take the apex, we go beyond the apex of the cut in the mucosa, and then we suture the vaginal mucosa first. Common sense. We close the vagina starting above, then yes, mediolateral. Okay, very good. Mediolateral episiotomy, that is the one which is given most common, mediolateral. Okay, after that so you close the mucosa, then we are going to close the muscles. Okay, muscles would be there, so we are going to suture the muscles, and then the muscles ke baad we are going to obviously last close the skin. Okay, and then we can suture the skin. Okay, so all of you know. Yes, was this the question? Mucosa, then muscles, and then skin. Is this understood to? Yes, all of you correct, all of you correct. C, then B, and then A. That was the correct sequence. Yeah, what is the sequence was asked? Perfectly correct. And mediolateral episiotomy was asked. Very good. I'm sure all of you must have got it correct. OG in the chat box. Yes. Now this I'm not too sure. This question, some students told me yes, this was there. Was it amenorrhea also given to you? Secondary amenorrhea, I think, was given to you. Amenorrhea, along with history of galactorrhea. And then the question was that what could be the cause or something. What was the question? Can anybody help me? And obviously we know that the prolactin, if it is elevated, I told you prolactin is going to cause combination of that galactorrhea as well as amenorrhea, and that's why it is also called as galactorrhea amenorrhea syndrome. Okay, galactorrhea amenorrhea syndrome, when we get that is because of elevated prolactin levels. Yes, secondary amenorrhea was mentioned. Excellent. Chalo. So patient of secondary amenorrhea and secondary amenorrhea. Excellent. Okay, and when history of galactorrhea, to confirm over, there's nothing to be, absolutely nothing to worry. And obviously in all patients of secondary amenorrhea, rule out pregnancy first, and then we have to treat prolactin and thyroid disorders. We do the investigation, TSH prolactin should be done, and then we proceed for the progesterone challenge test in a patient of secondary amenorrhea. And just by the way, just extra bonus information, pregnancy is the most common cause of secondary amenorrhea. Okay, pregnancy is the most common cause of secondary amenorrhea. Okay, yes. Yes, moving on to the next MCQ. Third degree prolapse image was shown. I think many students confused with inversion image. No, uterine inversion was in this year's FMG exam. Third degree prolapse image was shown. How will you know? The cervix will always be the leading point. Cervix will always be the leading point. And when the cervix is outside the vaginal opening, vaginal introitus hota hai. Suppose if this is the vaginal introitus, this is the vaginal introitus and the cervix is outside, that is the third degree prolapse, and it is because of broad ligament and round ligament are the false supports of the uterus. Okay, they do not have much strength. They are the false supports of the uterus. Yeah, cervix was seen, correct. Cervix was seen, so it's a third degree. Even fundus outside is 4th degree. So cervix was seen, that's a third degree. And cardinal ligament, or what is in the option, Macken-Rods. Okay, cardinal ligament is the answer, or yes, anybody else? Anything else was there? Cardinal ligament or Macken-Rod ligament, they are the true strength or the true supports of the uterus. Okay, if along with this other option was asked, was other thing which could be asked, yes, Macken-Rod is in the option, superb. Yes, so that is the answer. Macken-Rod's ligament. Another name is cardinal ligament. Another name is transverse cervical ligament. Transverse cervical ligament all mean the same thing. And another option is uterosacral ligament also. Okay, yes. So basically both. So both were there. Uterosacral and cardinal both were there. But then cardinal ligament or transverse cervical ligament, that's why it's called the cardinal, one of the main support. And levator ani muscle is also the pelvic floor. Okay, pelvic floor is also a good support. Okay, pelvic floor is also a true support. Okay. Yes, moving on to the next MCQ. Again, I am sure your pathology teacher must have also told you. Now, was this an image or an ultrasound tha, ya only image was shown, or only it was a clinical case scenario? Ovarian mass was given, or a adnexial mass was given, adnexial mass given, and elevated CA 125, so high, elevated CA 125, I think more than 1000 was given, 1000 international units per ml, and I think papillary growth was given, or a multilocular tumor was given. We know that non-adenoma, serous cyst adenoma, CA120 will not be so much. Okay, normally it is, image was there. Okay, superb. So this was an image. Okay, and granulosa cell tumor mein to we know inhibin is elevated, teratoma, dermoid. Okay, dermoid mein nahi, serous cyst adenocarcinoma, yes or no, real image, perfect, super. Okay, so adenocarcinoma image, we'll replace this by the image, but perfectly correct, and I'm sure all of you got it correct. Anything confusion? No doubt. I think it was a simple MCQ, even if you have not seen the image before. Perfectly correct. Why? Because sir, elevated CA 125, serous cyst adenocarcinoma, not cyst adenoma. Okay, and teratoma is the dermoid benign, and granulosa cell tumor mein inhibin hota hai. Okay, CA 125 elevated. I think something else was the multiloculated tumor, or what else also. Okay. Solid areas were seen, something like that was also mentioned. Some solid areas, yeah, scarring was seen, solid areas was seen inside the tumor, and CA 125 elevated. Yes, very good. Now this is again superb MCQ, basically just testing your basic knowledge along with physiology in a 28-day cycle. If a lady has got a normal 28-day cycle, day 21 to day 25, and hormonal levels were given to you, what is going up and what is going down, isn't it? Yeah, okay, yes. So what is going up, whether estrogen up, progesterone down, ऐसे 4-5 option दिए होंगे, and what it is, anybody? Yes. So basically we know that day 21 is what, which is the luteal phase. Basically they are asking you for the luteal phase, and what have I taught you? Ovulation, corpus luteum, progesterone. Ovulation, corpus luteum, progesterone. After ovulation, corpus luteum is from, and progesterone is going to be elevated. Progesterone is going to be elevated. What was else? Other things in the option also you can see, and this is our picture. All of you know this. Okay, sir, LH will already peak before. LH surge happens before, then LH levels are going to be low. FSH also role is over. FSH is high. FSH is basically going to increase. FSH is increasing in the follicular phase. Okay, in the follicular phase, which is your FSH is growing. FSH is going to increase so that the follicles start growing, and that is your proliferate. That is your proliferative endometrium. Endometrium is growing under the proliferative endometrium under the influence of estrogen. Okay, yes, estrogen, yes. But estrogen will not be so much decreased, but progesterone definitely high. Estrogen also then remains high. You can see the graph over here, but then your this one. Okay, your FSH and LH both are going to be low. Is this clear? Because there is no role. We don't want another follicle. Okay, so FSH, LH low, progesterone definitely high, estrogen high. Yes, decreased. Superb. Yes, decrease in LHFS. Superb. Yes, that is the answer. Perfectly correct. Very good. So progesterone is going to be on the higher side. LH ka role is over. FSH ka role is also not there. Okay. So that is the answer. I'm sure all of you must have got it correct. Okay. And this is also a nice question when the patient complains of decrease in fetal movement. Okay, decrease in fetal movements and no decelerations are seen and acceleration is seen in 20 minutes 1. So we know what is it. You don't directly need to go for immediate LSCS or induce the labor at 36 weeks. Basically, we know that NST is done for first 20 minutes, and if not, because for reactive NST, I need 2 accelerations. Okay, I need 2 accelerations. So if in the first 20 minutes the NST we are not getting it, we can do it in another 20 minutes. Yes, very good. 40 minutes. Very good. So NST totally 40 minutes. So if 20 minutes was due, you can do 20 more. Basically 20 minutes more can be done. And again, remember, if the NST is not reactive, because at least 1 acceleration has come, no deceleration clearly mentioned. So then just to see BPP, biophysical profile is better. Just by the way, I'm teaching you BPP better than NST. In biophysical profile also there is a problem. Then yes, we may want to do LSCS or induce the labor depending on the criteria. Okay, so NST, a nice MCQ. Basically, you know the criteria as sir, in 20 minutes if only 1 acceleration is there. And I think there was one more question, which if you can tell me, some 40-year-old lady. So were there 2 questions on the perimenopausal age group? We have discussed one over here. So this was all the 20 questions what we have discussed. Totally 20 to 21 questions. Anything else if it was there, you can kindly let me know. Any other question if you feel we have missed out, or any other question which you feel sacrospinous, अच्छा उसमें sacrospinous ज़्यादा, that's okay. Sacrospinous for mainly for vault. Sacrospinous ligament is mainly for vault support, and that's why we do sacrospinous fixation. So cardinal ligament will be the answer. Okay, sacrospinous is mainly for the top of the vagina. Okay, this is the uterine prolapse. Sacrospinous ligament, sacrospinous was there. Sacrospinous is mainly to sacrospinous is to mainly support the top of the vagina, the vault, and that's why we do vault suspension. We use sacrospinous ligament. Okay, so cardinal is McEnroe is the answer. Yes. And I think there was one more question. Some student told me some USG picture was given. One more USG picture. Was it something in the cavity shown to you? If you can tell me what exactly was the image. Was it a submucosal fibroid or was it what inside the cavity? But this hysterectomy specimen is, I think, C endometrium only. Okay. And I'm sure all of you must have done very well. So that was our short recall. Today is your day to relax and enjoy. I'm sure please tell all your friends and colleagues and juniors about this OGGuru app, and if we have touched you and if our teaching has really helped you out, okay, you can shower the love by hitting the like button, sharing this video with all your friends. And all of you know this superb, the notes, everybody has told me, sir, that the notes are so crisp, we can revise the entire notes in just 1 to 2 days. Thank you, Dr. Thank you. Okay. Okay. Thank you, Dr. Harish. So you can just tell all your friends and colleagues and tell them also, those who have done not so well. Don't panic if this is your first attempt. Many have just given the exam just as a trial. Many of you are doing your internship, so absolutely don't worry, there's always a second chance. And if you are going in for November INI CET 3 months, and best is to directly take the 12 months master class is available to those who are directly preparing for the next year. Do not waste your time now and start your preparation. Launch 30 is the discount coupon code. You'll get everything, my mentorship, guidance, main theory lectures, beautiful handwritten notes, doubt solving. Mentorship is available. You can get in touch with me on phone and WhatsApp on this number, and we will see you soon. And do subscribe to the OGGuru channel. And bye bye, best of luck, and thank you very much. And if any other question which you remember, please post the question on my WhatsApp also. And bye bye, best of luck, thank you very much.